You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation. So what'd you say again? Tina Newert, Dr. PT, pressing, valve salving. I told her, if you keep doing that, you're going to throw a blood clot. I mean, you're going to throw like an embolus. So you're going to stroke out on him. She said, if I could get to 100, I would take it.
Yeah.
I love it. Yeah, you said that.
But not seriously, patients that have an illness.
Yeah.
That's serious.
Yeah.
But maybe.
Yeah.
But maybe.
Yeah, she doesn't want to seriously have one. But hey guys, welcome back to the 40 Fit Radio and welcome back to the 40 Fit Nation. This is Coach D and
Yo, it's Coach Trent.
And we are going to talk about medical testing today. We're going to the title of this episode or whatever you want to call it is You're Not Your MRI. You know what an MRI is? A magnetic resonance imaging. It's a diagnostic test, but we're going to talk about how, here's the deal. Trent and I talk about this kind of stuff ad nauseum all the time in the gym. When we're in the gym, we talk about our clients. We talk about my patients. I share ideas with them, not patient names, no confidentiality or HIPAA issues. But we share just about people in general and how their psychiatric state or their psychological state and their emotional and physical state all interweave and intertwine. And we were actually talking about a client recently that has kind of had a back tweak and has some findings, some more serious findings on an MRI. But at the same time, how other findings on this MRI don't necessarily warrant or reflect the need for medical intervention,
right? Or
produce his symptoms or her symptoms, whoever it might be. And so we're just talking about this whole concept, this bigger concept of you're not your MRI. In other words, you're not your label. We as humans, I find that my patients over the years that they have this tendency to want to label themselves,
right?
Like I'm the knee patient, or I'm the back patient, or I'm the bad neck patient, or I'm the bad knee patient, or I'm the bad elbow patient.
Yeah,
whatever.
It's like all those guys that like used to play college ball. They all threw out their arm. You know?
Yeah. I was an amazing football player until I blew my knee out.
Yeah, blew my knee out.
You know, and you hear all these stories, and I think sometimes we psychologically use that as a way to avoid the actual issue was, and there's many reasons why people can't perform physically in sports or in daily living, and some of them relate to actual physical limitations. And we're not downplaying those. So I first want to say, as a disclaimer first, as a DPT and someone that still treats patients and practices, I am not giving you medical advice in this podcast. I am not suggesting that you do anything or talk to your doctor about anything. What I'm asking you to do is to think. And to consider some of the logical reasoning that we're going to talk about today on the podcast, and consider the actual data before you and the logic, and not base your decision on, humans kind of have this readiness to change, this fear avoidance modeling, and not base your decisions on pure fear alone or the lack of any healthy fear too. I mean, there's a balance in decision making. So we're talking about this concept of how people think about diagnostic testing today, specifically in the medical community. So, here are some examples of diagnostic tests. We got X-rays, we got MRIs, we got CT scans, we've got EMGs, we've got ultrasounds, sonography,
EKGs, all sorts
EEGs. We've got MRAs, magnetic resonance, arthrograms or arteriograms, I believe. We've got actually a test called an arthrogram, which is an MRI of, let's say, the shoulder or a joint with contrast dye injected into the joint so that it fills the space and fluids, and we can look specifically at tears and different structures in there.
Right.
But all of these tests have a certain level of specificity and sensitivity. In other words, how often they will statistically rule in the condition and how often they will rule out the condition based on the statistics of the accuracy of that particular diagnostic test.
Sure.
But what we see happening sometimes is that people will get here's the general situation. People will get let's say an X-ray or an MRI. Let's say an MRI because that's probably the classic one now.
Yeah.
Because MRIs have become so common in Western medicine. A lot less common in the UK and in other countries where they order a much lower diagnostic rate of testing per patient population.
Interesting.
Specific to diagnoses, yeah. And so someone will get an MRI, and maybe they'll have a little back pain, a little back tweak recently, and they'll find in this MRI that they had, all these different conditions that they never ever knew about.
Yeah.
They were hiding in the background, in the shadows.
Bulging discs and stenosis.
And spondylosis and all these different conditions, facet arthropathy.
Yeah.
And we have all these, as medical professionals, we have all these fancy, daunting terms for these conditions. But here's the interesting thing. In some of these conditions, so let's just take some of these. Facet arthropathy, like degenerative facets. That is a condition that has occurred over time and has been there potentially for years.
Yeah.
Prior to an incidence of back pain.
Right. And it's really just, my understanding is facet arthropathy is simply it's sort of like the cushion in between your facet joints.
It's cartilage.
It loses a little, that cartilage just kind of wears out over time. It loses a little bit of height. And so.
Yeah. And you can get spondylotic changes. In other words, you can get spurring and you can get some stenosis in those areas.
Narrowing of the
overgrowth
canals.
And narrowing. And you can get a lot of things like this, but facet arthropathy would be one of them. Spondylosis, again, a condition that occurs over time. Spondylosis means overgrowth of bone. Basically, you get too much bone, which can cause a condition called stenosis. And stenosis basically just means narrowing of a hole or an opening. And when you've got structures that are going through that hole or an opening, like an artery, a vein, a nerve, or you've got nerves, a bundle of nerves going through an opening and the opening gets too small, sometimes it can pinch on those structures and cause pain or symptoms or motor or sensory problems. In other target organs, other areas that are being fed information or nutrition or whatever the structure is, it's going to those target organs.
Right.
So you can get stenosis, but again, that's been there for a while. You can get degenerative disc disease. That's been there for a while. These are all chronic conditions that have been in the average human spine. Probably 8 out of 10 people, maybe even higher, have some of these normally occurring aging conditions that occur in the human spine because we're bipodal, because we're vertical, because we fight against gravity, because we have all these other genetic and external factors. Our spines wear over time.
Yeah.
Now, if you took a 20-year-old that had the common findings of someone who was maybe in their 60s to 80s, then that would be abnormal. That would be pathological.
Sure.
And if you took someone who was in their 60s to 80s and they had some of these findings and they had the signs, the clinical signs, which means physical objective signs that we can measure as a clinician, as a doctor PT or whatever, we see muscle weakness, we see atrophy. We see that there's a reflex that's diminished. We see a lack of sensation when we test sensation on the skin. We see all these things that I can measure when I see the patient. I can objectively say, hey, your reflex is gone on the right knee. So maybe the L2, L3, or L2 to L4 nerve root has been affected.
Sure, yeah.
Or the Achilles reflex is diminished or gone. Or you have no sensation in this path on your leg, representing that the dermatome has been affected. So those are objective measurements. But then if someone says I have pain in a region, it doesn't mean it's not real, but I have to map that pain. I have to find out if that pain is referral pain. Is it directly in that area? So there's all these different things of signs and symptoms. Symptoms are what you tell me you have. Signs are what I see or can measure.
Right.
Now, an MRI presents us with certain signs. But it doesn't mean, along with many other diagnostic tests, that test is actually telling us that that problem that we see on the MRI is causing the problem that we have in the clinic.
Right. I think that the classic thing we see with MRIs in particular is that you can look at a bunch of different spines on an MRI, and you'll see some that look perfectly fine for the age of the patient. And these patients have tremendous back pain.
Correct.
And then you can see backs that structurally look wrecked on the MRI, and the patient has no back pain.
Yeah.
There's not a very good correlation between structural findings in the MRI and pain symptoms.
Yeah, absolutely. And I think, I've had several patients over the years, a bunch of patients, that have had completely asymptomatic backs most of their life and had an episode in their life where they went to go pick up something or bend over or they were doing something.
Sneeze too hard.
In daily life. And they had a back tweak. They had pain. They might have had even referral pain. They might have had some weakness and other problems. It doesn't mean that the problem wasn't there all the time. The problem just wasn't producing signs or symptoms. That they knew of at least, or that they were aware of. Some people are their self-awareness is poor, and they might have had some weakness that they didn't know about it. They might have had some numbness or tingling or numbness or decreased reflex that they didn't know about. But I think in general, what we're saying here is that just because you have an MRI that shows positive findings, then there's an impression by the radiologist. That doesn't in and of itself mean 100% that is the source of your clinical problem or what we need to treat. We don't know. We have to take that test along with a bunch of other clinical exam tests, your report. We go through a whole process, a whole triage process of looking at your subjective history, taking all your medical history and information together. Then we get objective tests in the clinic. Then we get objective tests that don't relate to the exam but are referred out, like an ultrasound or an MRI or an X-ray. Blood work could be one of those. Many different things. An EEG if you were, a neurosurgeon or a neurologist, or an EKG if you're a cardiologist or whatever. And then a stress test could be one of those, a submax GXT. And then we take that information and we pair all that stuff together, and it's like a jigsaw puzzle. Hopefully I have enough pieces to put together. We say if it walks like a duck, quacks like a duck, looks like a duck, and flies like a duck, it's most likely a duck. And so that's what we're trying to do. But the problem is as humans, what we do is we get this study done, and what we're really talking about is not a particular incident like this necessarily, but it's the whole concept that humans like to identify themselves by a label. And we call this in the medical profession the identified patient. The patient who they medicalize everything.
Right.
And they're going to be that identified patient. Every little tweak they have in their body, every little problem they have, they need to psychologically and psychosomatically assign that to a problem that they can identify and put another label.
Yeah.
It's kind of like a badge. You put another badge on them. Now, why they want to wear that badge, I'm not real sure. There are many different psychological reasons for that. And I'm not saying this person doesn't have a problem, but they may be attaching labels to themselves that are really not their problem.
Right.
And that's going to make it harder for them to both psychologically, emotionally, and physically heal and get back to normal life.
I imagine, sitting around in a group, you raise your hand. Hi, my name's Trent, and I have back pain.
Yeah, exactly.
Right?
Yeah.
And
I'm a backaholic.
Yeah. When we hear, we joke about it, but we hear this all the time. I'm sure you've heard this yourself. You'll meet somebody and, hi, I'm so-and-so. Oh, yeah, nice to meet you. So what do you do? Well, the other day I was like going on in this, and they just like all of a sudden they launched without prompting into their whole
medical history.
The whole medical history.
Yeah, they are the patient now.
Right.
Their new job is being a patient.
That's right. And they, they're just constantly going to doctor's appointments and talking about, it's just like a drama. It's like a soap opera.
Yes.
It's like, met with the sports med today, and he said I have adhesions, in my right leg that we had to roll those out. And
I get people all the time in our gym population and in doing one-offs and doing coaching, barbell coaching or some type of fitness coaching here and there. They'll say, my doctor told me that I sprained my hamstring and that's why it's hurting. Well, when did you do that? Oh, about 6 months ago. Well, have you been squatting? Yeah, I've been squatting. Everything's fine. I said, whatever's healed is healed.
Yeah.
Now, it may not have been adequately strengthened back to a level, and you may have some adhesions that developed in there, and you may pop those again if you're not careful, if you overstretch the muscle under load because you didn't adequately rehab it during the healing process, the primary healing process. But the reality is 9 times out of 10, whatever you were diagnosed with went through the normal pathological healing timeframes for that tissue.
Right.
And so you may have other problems, and some of that we've talked about in prior episodes with pain neuroscience, principles, that sometimes our brain remembers the fact that we had pain there. And we have to disassociate ourselves from that pain. We have to start recognizing that what we might actually be feeling is discomfort from the rehab process, or discomfort and not re-injury pain. We want to expose the person to, like we've talked about, exposure without danger. We want to start loading the tissue, using the tissue, getting them moving. I haven't found a single diagnosis one, or a single MRI report or test report one. Most, I can't say not a single, but most, the large majority of them can be treated by exercise.
Sure.
Can be treated. Almost everything gets better with exercise. There are very few conditions that don't. Now, I'm not downplaying the fact that people have real problems. I treat them all day long. I'm just saying that in many cases, let me give you an example. I had a patient the other day that came into me, and she had tweaked her shoulder during a workout. First of all, she wasn't training, she was exercising. She had previously been training in a barbell program. She stopped for a while, and then she thought she'd just go in the gym one day and do some heavy pressing and bench pressing on the same day.
What could go wrong?
Yes, exactly. Well, that was smart. And she said she tweaked her shoulder. Well, she didn't feel a pop. She didn't feel a snap. There was no, physical activity that occurred during the workout, other than she felt a little bit of a twinge. And later that evening, she had severe pain in the shoulder. Now, I'm not discounting the fact that she didn't have severe pain in the shoulder, but she also was going through a very emotionally stressful time of her life. She had relationship challenges. She had living challenges. She had transportation challenges. She's trying to find her new path in this life, all these different things. And she's also a very emotional, labile person.
Yeah.
So you put all those things together and it's a perfect storm. I'm not saying she didn't have shoulder pain, but I'm saying that her very personality traits and her environmental stressors significantly influence how that pain is going to be rated and how it's going to be scaled, and how it's also how she's going to allow you to intervene in her care because she feels so injured. And so now she's the shoulder patient.
Right.
And her brain kind of holds onto that because it's kind of a self-preservation type modeling. And so
Yeah.
I think people do these things for many different reasons. Now, if a guy comes in and he basically, falls on the ground, lands on an outstretched wrist, and you look at his wrist and it's swollen 2 times the normal size, and the guy's got a wrist injury.
Right.
No doubt. And even the guy who's not swollen 2 times, if he's got soreness and palpation and reduced range of motion and all these different clinical signs and symptoms, then he injured his wrist. But there is a normal healing process there that should 99.9% of the time do pretty well.
Right.
You
I wonder how much of the identified patient is externalizing. You externalize the problem, right? If when you medicalize something, right?
Sure.
You're kind of abstracting it, or you're putting it beyond the scope of control of yourself, right? You're basically saying
medicalizing it gives it validity.
Okay, yeah.
It gives it validity.
Okay.
And it also potentially takes it outside of your hands of self-control and self-intervention to try to improve or solve that problem, and puts it in the hands of and I'm holding the air quotes, experts.
Yeah, there you go. That's what I was trying to say. So in fact, it doesn't abstract the thing. It actually makes it more concrete. Experts. Right.
And I also, this is the person that has, I've never figured this out. This is the person that has no true major diagnostic findings, but they have a movement therapist, which I still haven't figured out what that is. They have a physical therapist, and they have a sports medicine physician, even though they're not actually in sports.
Right.
They might lift a little. They have an orthopedist. They have a neurosurgeon, even though they have no neural involvement. And they have all these, they have a massage therapist. You got to have a massage therapist.
Of course, yeah.
And a yoga practitioner.
Yeah.
And a
Preferably,
they may have a life coach, too.
Preferably all of those titles preceded by the word functional.
Yeah.
Not just a massage service, a functional massage
Not
service.
just a sports medicine physician, but a functional medicine expert. But they have all these different clinicians to treat their medicalized body. That person would never survive in a primal existence. Natural selection would have already selected them out. I hate to say it that way, but now I'm not to say that someone that with a serious medical condition, take something like cystic fibrosis or something like that, a serious medical condition that they don't need a team of medical professionals. That person might have a pulmonologist, a neurologist, an orthopedist, a rheumatologist. They may have all these different people that are treating, just a hospitalist, someone that's treating that problem, even a nutritionist. And so we need appropriate medical interventions. But yeah, I think you're right. I think what people do is, in some cases, not all, but in some cases, people medicalize things and hang on to these diagnostic tests because it validates their problem for whatever reason they have.
And it hands, I think the important part, and you said it earlier, is that it places the control of the problem in the hands of someone else rather than yourself, right? That makes it easier, because the hard thing to do, like we said, especially if you're stuck in that biopsychosocial pain loop, right?
Yeah, sure.
It's hard to face your fears.
Oh yeah,
right? And
they're legitimate.
The fear is real.
Yeah.
But the expectation of the fear is not real.
Right.
It's and so when you place the problem in someone else's hands, then
self-responsibility is absolved.
You're
absolved from the situation. You're distanced from it, and you're relying on the expert to fix you. And I find that people that posture themselves in a passive role of identification. Years ago, back when I was an early physical therapist, I did a professional residency with a guy by the name of Dr. Leonard Matheson. And this is really interesting because people want to poo-poo me on this podcast about the fact that I'm saying everybody's problems are in their heads. Hey, I've had shoulder surgery, back surgery. I know there's real problems, but this guy's name was Dr. Leonard Matheson. He's a PhD psychologist from California. And he developed an organization called ERIC, the Employment Rehabilitation Institute of California.
Okay.
And he had a course and a 2-week-long residency that you could attend. And basically you learned how to perform what's called a functional capacity evaluation for mostly injured workers, people that were injured on the job, whether it be workers' comp or self-insured employers. But you were learning how to identify, evaluate, and treat an injured worker in a rehabilitation program to get them back to work. And so there are a lot of issues that relate to the person who gets injured at work versus someone who just gets injured at home. There's many other players. There's the employer, there's the doctor, there's the insurance company, there's the fellow employees, there's the HR department. There's all these different issues that relate to. There's the workplace environment. There could be everything from harassment at work to dissatisfaction with the job, whatever the issue is. But during this course, we learned about all the different patient types because people generally fit in some of these patient types. You've got the identified patient. This is the person who basically says, I am a patient. I will always be a patient. I am patient. Hear me roar, like Helen Reddy from years ago. I'm a patient,
Right.
and you can't take that away from me. And I will always be a patient. They will be their lifetime patient.
Yeah.
That's the person most likely looking for long-term disability. And there'll be a 35-year-old able-bodied male or 45-year-old able-bodied female working to get Social Security disability when they have no significant physical problems.
Yeah.
Then you've got the game player. This is the person that's actually gaming the system. And very few people I found were true game players.
Sure.
You know?
Yeah. I think it's generally way overblown. You know, people.
And we also call them the malingerer. They're malingering. They don't have any real problems, but they're trying to make it up to be sick, you know?
Right.
'Cause they want to be off work or they have issues. And some of the issues are real issues. I've had people malinger before because they need to be at home to take care of a sick loved one, but they malingered a problem. The reason why they were malingering was a valid reason, but they shouldn't have been malingering. That's not a valid response to the problem. And then you have what we would call the symptom magnifier. Now, this is the hard one. And I think a lot of people fall in to the identified patient when they find out these diagnostic tests and the symptom magnifier. The symptom magnifier is someone that actually has a real physical problem, but they magnify those symptoms. Sometimes they downplay those symptoms, but they magnify those symptoms one way or another on the magnification spectrum.
Yeah.
Okay. For one reason or another, we don't know. Our goal is to find out what that secondary gain is. See, our goal is to find out why they want to be that patient, why they want to have that problem, why they're holding on to that diagnostic. I find that a lot of people come into our gym. You see this every single day, Trent, when we have people do walk-ins or want to check out our gym. Well, I can't do that because I got a bad back. That's not a valid response.
Right.
That is the identified patient modeling to some extent.
Yeah.
I'm the bad back guy. I've been told. Now, they may believe that, and the reasoning for that is because the experts have told them. So they've put their health in the hands and their future in the hands of someone else versus themselves. So they're absolved of responsibility.
So, all right. And I want to get to, so what does this mean for you? Right.
Yeah. What do we do with this info?
I think the problem,
other than we're kind of bitching and moaning about it.
Okay. So we know we have these people out here. Well, here's the problem. Let's say you got back pain, because that's the most common. We talked about that. It's by far the most common type of pain. All right. You got back pain. All right, you might have some findings, as a result. Okay, in some circumstances, you might have findings severe enough to warrant like a fusion surgery or something, right? But how many cases is that, right?
It's minimal. I mean, most spine surgeons are going to operate on somewhere between, well, they should, if they're selective, 3 to 5% of their population, total population, and out of those, one of them might be a fusion. I mean, probably less than 30% of their caseload will be fusions, or some reconstructive or stability procedure like that. It's going to be pretty low. It's going to be pretty low.
So the majority
and should be.
Sure. Yeah. Because we won't even go down that rabbit hole. But there's not really great.
No, the outcomes
are not very good in terms of pain, right?
No.
So you have a choice here, basically. You can either decide to train through pain and get stronger, which we know 100% of the time works, right?
Well, and that's go ahead. Say the rest. Say the rest.
And or you can decide to let this finding dictate what you do with your physical life. Decide not to train, and you're still going to be in pain.
Yeah, exactly. I always tell my patients this way: you can be strong and have less pain, or weak and have more pain. But we do have to recognize this, that the large majority of conditions, we're not just talking about backs, we're talking about knees, shoulders, elbows, wrists, hands, feet, necks, thoracic spines, hips, whatever. The muscular issues, tendon issues, whatever it is, even many vascular issues, and lymphedema and other things like that, most neurological issues. The only thing in the literature that is shown to be effective across most diagnoses. I almost want to say all there, but I know you can't. All would be generalizing.
Sure.
Yeah, but the large majority of diagnoses, the only thing that has been shown to be effective to improve quality of life, improve functional scores in our patients and in our client populations, only thing is exercise. It's training. Now, it has to be the right kind of exercise, the right kind of training. But exercise and training have been shown to not only help the large majority of physical problems, but also the large majority of mental problems too, as you've seen with Dr. Pooter's podcast and his information. And so, it's important for us to see that what I want you to hear as an audience out on our podcast is basically this. If you've been told that you've got a bad back through an MRI, be logical about it. Don't let fear, false expectations appearing real, control your next decisions. Be logical about it. If you've got a bad shoulder, you've got 3 other main extremities and a trunk that you could be exercising and training.
That's right.
There are creative ways to do it. That exercise is going to help your well-being, your sense of well-being, your blood chemistry. It's going to help your hormone levels. It's going to help you neurologically transfer some of that information over to the bad limb or the injured limb and help the healing in that limb too. So the science and the data is very clear that exercise and training can only help you, even in the non-injured areas.
Right.
So I get the patient all the time that comes in and says, ever since I got this injury, I gained 30 pounds because of this injury. No, you gained 30 pounds because you eat too much.
Right.
And because you decided not to push away from the table and you stopped moving.
Yeah.
And you didn't alter your diet because of the injury. To say I gained 30 pounds because I got injured is to then again assign that responsibility to the injury to your weight gain.
Right.
No, it's your responsibility.
Yeah. And just practically, you can't control what happens to you. Right. We don't get to choose
sometimes
when we have an accident.
Yeah,
or,
sometimes. That's true.
You fall down the stairs. It's just a freak accident,
Someone
right?
hits you from behind and you
get in a car accident, right?
Yeah.
You can't always control that stuff.
Right.
But we can control what we do about it, right? And I think that's kind of my sort of pet theory. And I don't know, you have to ask Dr. Pewter, go listen to his podcast to learn more about this, but is that when you take active control of your life, then it improves your mental state, right? And that's and that's from a practical standpoint. It's like, okay, well, what are you going to do with the information? Like, oh, you have a bad back now.
It's crazy powerful, man.
So what are you going to do with that? You can't do anything with that, right?
It's crazy powerful when you recognize that you might have a physical problem, but that you potentially possess the solution in your own hands.
Yeah.
It's extremely powerful. And when you get to the point where you recognize that not only are many of these diagnostic tests, I mean the specificity and sensitivity for an MRI is it's in the 40s in both of them. They're not I can't tell you how many patients have had reported in the diagnostics a full thickness rotator cuff tear in the shoulder, and the doctor gets in there with a scope and he finds no cuff tear, or vice versa. It doesn't show the cuff tear, and the doctor gets in there and it shows a massive cuff tear. So it's only part of the equation.
Yeah.
And just because you have a finding, air quotes, doesn't mean it's producing the dysfunction or the problem that you have in the real world.
Right.
And more importantly, the solution most likely is in your own hands, and it's in the form of exercise, training, lifestyle modification, nutrition, rest, sleep, healthy living is where it's all at. And so you're not your MRI. You're not the identified patient,
Absolutely.
And I think sometimes we get so, I think it all boils down to, for whatever reason, people like to defer responsibility. And I don't mean that in a bad way always. There could be some fear there, some behavioral fear. There could be some trust issues there and people have been mistrusted, or they've been their trust has been violated in relationships or in situations. I have a friend that his father died of a heart attack fairly young because his mother had cancer for years, and the doctors made so many mistakes with her along the years that the father was so distrustful of the medical industry that he wouldn't listen to his own signs and symptoms of heart problems prior to his massive heart attack. He knew he had a heart problem, but he was just scared to go to the physicians. He was so bitter about it, and he died of a heart attack because of it.
Yeah.
He could have treated that.
Yeah.
He could have treated that. So, yeah.
For those, all right, so if you haven't tuned out already, all right, I know we have a few MDs and clinicians that listen to this show. I want you to go to Dr. Pewter's podcast. It's called Psychiatry and Psychotherapy. He did a multi-part series on the Therapeutic Alliance. And it's just simply it's the simple concept of displaying empathy in the clinic. And he goes through a bunch of research that's been done on findings, and it shows very simply that if you are able to empathize with your patients, the outcomes improve, even if the treatment is exactly the same.
Absolutely.
And a lot of what Dr. Puder talks about is that when he's speaking with a patient, he tries really hard not to use medical language.
Right.
He does the tests that need to be done, but he tries to explain things very simply.
Yep.
And I can empathize with physicians, right?
Yeah.
They may not get that training, right? They've got a lot to learn.
So
right?
it's personality based.
Some of it might be personality, but you owe it to yourself and you owe it to your patients to try to develop a little bit of empathy.
And I don't care what the problem is. It doesn't really matter what the problem is. When I'm treating someone in the clinic, I'm a logical, reasoning therapist in the way I interact with my patients. That does not mean that I don't do that with a sense of empathy and sympathy towards them. I don't walk into the treatment room and hit them across the head, hit them on the back of the head with a bat.
Right.
That doesn't work either. I figured that out years ago as a younger therapist. What works is sharing with people, getting to know people, getting them to trust you, you trusting them in their intentions, them trusting you, and then working them through step by step into a position of eventually greater self-control, greater self-reliance, greater personal responsibility to know that this is the only body they got. They better make the best of it.
That's right.
And
so now let's flip it around. If you are the patient, right? I think this is interesting. When you talk to people in everyday life, people have opinions about everything.
Yeah,
right?
yeah, sure.
Dating. Oh,
sure.
Well, you got to do this, and this,
there's
right?
an expert on every corner.
But then you get to any sort of physical matter, like whoa, dude, I don't know.
Right.
You can't. Are you a doctor? You can't.
Exactly.
You can't have an opinion on that, right? You need to talk to a doctor, right? It's like we've kind of. It's kind of taboo to talk about medical subjects if you're not a clinician, right?
Yeah.
And so, as a patient, though, it's your body is your responsibility.
Yeah, absolutely.
Right? You are your own best advocate.
Doctors, medical professionals make mistakes too. We make mistakes too. And sometimes we need to be corrected. And I've been corrected by my patients by a mistake that I made in a protocol or something I did in the clinic or whatever. So none of us are flawless. None of us are without error.
Right.
Our goal is that we never err in a manner that's malicious or malfeasant or that's dangerous to our patient or even in our gym environment. If we don't keep up our equipment here,
right.
then we're responsible for that. We're negligent. We need to be keeping things clean, keep things in good working order. But at the same time, I think what we're really saying on this podcast today is that just because you have modernized medical findings that someone wants to assign to you from the medical profession, or your best buddy had that problem and he had this issue, don't prejudge it. Use logic, use reason, be smart about it. 99.9% of the time, you can continue to exercise and train. Don't use your problem as an excuse to not do something, because doing something is always better than doing nothing. And that's about it.
Yeah. When it comes to working out, absolutely.
Yep. All right. So that's all we have for you. So, hey guys, thanks for joining the 40 Fit Radio and thanks for joining the 40 Fit Nation. If you want to check us out on Instagram, you can find us at 40 Fit Radio. You can find Trent at Marmalade Cream. He said he was going to change that name, but he never did. I don't know why. But you can find me at Dr. Deaton. I think he likes that name. And you can find us on email, info@40fit.com. And you can go to our Facebook page, 40Fit Masters Community Group. And then also go to 40fit.com and click on the 40 Fit Radio tab. Thanks for joining us, guys, and have a great day.
Thanks. See you next week.